laparoscopic surgery of the Chinese University of Hong Kong. She has vast interest in all the endoscopic surgical procedures, including conventional gastric esophageal cancer, and now she embarked on a special interest in peritoneal surface malignancies as well. She is well known to be a pioneer and also active interventional endoscopists and performing all these EUS guided biliary and drainage procedures. She has published over 70 peer-reviewed journals, and she is also in the research committee, subcommittee of the Asian EUS group. Today, Shannon would talk to us about the EUS guided gallbladder drainage, for who and how. Thank you, Sharon.
Thank you very much, Dr. Lee, for a kind introduction. So I'm afraid some of you may have heard this talk already before because I've given this talk for so many times. So I've modified with some new evidence, especially for EGBD in surgical, potentially surgical candidates, which is quite a hot topic right now. So if you look into the World Society of Emergency Surgery, the gold standard of treatment for acute cholecystitis, of course, if the patient is a surgical candidate, the patient should go for surgery. If the patient is not a suitable candidate, we should go for antibiotics first. And if it's successful, then you can consider delayed surgery, or if the patient is not a surgical candidate, then we keep observe. If the patient fails antibiotic treatment, the next thing we need to think of is a gallbladder drainage, and in the old days it's a percutaneous drainage, and nowadays we have the ET-GBD, which is the transpapillary drainage, or we have the EUS guided gallbladder drainage. So these is now incorporated into major guidelines, EUS-GBD. And we all know that emergency lab chole, I see a lot of surgeons in the floor, that it does come with some complications, and the most worrisome complication is a CBD injury. And the computer's battery is running low. Do we have a cord? Okay. So today we're going to focus more on this. So for patients who we intend for EUS guided gallbladder drainage. So in fact, for these patients, as mentioned, there are three options. So either a percutaneous drainage, or a transpapillary gallbladder drainage, or a EUS GBD. So of course, if we compare between these two endoscopic drainage, ET-GBD and EUS-GBD, we know that ET-GBD, I'm sure all of you do ERCP. It's a feasible technique. It's a very safe technique because it is trans-papillary and through the normal route. The only difficulty for this procedure is that for patients with acute cholecystitis, there is always a stone at the cystic duct. And to cannulate this cystic duct, which is very tortuous and blocked, may be very difficult. So there are now techniques to mitigate this, for example, using the spyglass. Professor Pranam Chai from Thailand has actually just published a RCT using ET-GBD as an interim for surgical candidates, and it was a positive trial. So there was less acute cholecystitis while the patient was waiting for a lap chole. So this is actually quite a feasible option if you do have the accessories and the technique to do it. So of course, as mentioned, the problem with this technique is that it is difficult, and the technical success rate is only around 75 to 90%. So for EUS-GBD, the beauty is that in patients with acute cholecystitis, the gallbladder is usually very distended. The problem at that time when this technique was introduced was that there was no appropriate stent. So we're trying to pull together two non-adherent organs, and if it's not done well, there may be bowel peritonitis, there may be pneumoperitoneum, and the patient is not a surgical candidate. So it may pose a lot of problems if this procedure is not done well. And however, now with all the new stents and new techniques, this technique is actually also incorporated to the ESGE guidelines, where if the patient is not a surgical candidate, EUS GBD is in fact a plausible alternative to PT-GBD. And in this, it also mentions that EUS GBD is actually superior to PT-GBD if the technical expertise is available. So this procedure actually started off at the very beginning by Professor Todd Barron in 2007. It was done with a plastic pigtail. Subsequently, it was done with a fully covered stent with anti-migratory flaps here. And it was still feasible at that time. And then came all these different lumen opposing stents. And of course, nowadays it is done via the hot EUS, which we can do with a direct puncture. So this is a distended gallbladder, failed PTC drainage. You can see that the gallbladder is still very distended because the contents was very thick and the PTC was not able to decompress it. So with this hot EUS, you can see that the procedure time can be very short and procedure can be relatively simple. So this procedure can also be performed, this is not hot EUS, with a new stent called the ZEUS stent. This procedure is a courtesy from Professor Teo. So you can see that this ZEUS stent is a new stent developed by MI Tech. It's a Korean stent. The design is very similar to hot EUS. Actually, Professor Itoi was the one who designed this stent. The full name of this stent is a ZEUS IT stent, IT standing for Itoi. So you can see that how it's deployed is when it burns through. To unlock it, you have to rotate this gray catheter to unlock it. And to deploy it is very similar to hot EUS, where you push it backwards. So it is a backward deploying stent. So after you deploy the distal flange, then it's very similar to deploying hot EUS, where you pull back the sheath, like the step 3 from hot EUS. And then you deploy in channel for the step 4, also like in hot EUS. And then you push the stent outward. So you can see the distal flange is right here. And now we're trying to push out the proximal part of the stent. So this stent will be used for wand drainage later during the live demo. It will also be available in the hands-on workshop tomorrow. So you can see and practice how to use this stent. So, of course, these procedures are all done in very distended gallbladders, and direct puncture is easy. It avoids the exchange of catheters. But for small gallbladders, and if you are not very familiar with the procedure, the needle-first approach is actually preferred because first you may consider injecting saline to distend the gallbladder further to make the procedure easier. Second, if anything happens, such as in this case, let's see. So in this case, it was done by one of our first case of our trainee. So the scope was not held very stably, and so the guide wire was not seen. And so they struggled to find the guide wire, and at the end, so am I able to fast forward the video because I can't see the bar in the. Oh, is it live? Oh yeah, okay. So the problem is the guide wire was lost during the view. And so finally, when we found the guide wire, so we deployed step 1. And he was unable to push step 1 in. You see it was hitting against the back wall. So with some struggle, he decided to, he pushed it all, step 1 all in. But in fact, you see from this retrospective video is that the gallbladder was pushed away instead of the stent being inserted inside the gallbladder. So what happened is when we deployed the distal flange, it was actually inside the lumen instead of inside the gallbladder. So with this case, with the guide wire in situ, it can be easily salvaged with another hot axial, another LAMS, or whatever kind of, you can use a fully covered stent or another lumen opposing stent. So with the guide wire, in fact, it is easily salvaged. So for small gallbladders, and if you're not very familiar, having a guide wire is always a good and safe backup. And after doing these, inserting these stents, with this new lumen opposing stent, we can clear the stones and hopefully can remove the stent later. So in the past, our protocol, according to the DRAC study, was that we will do a cholecystoscopy 4 weeks later. And with we would do a forward-viewing OGD scope with a jet function. We would insert it to the gallbladder and remove the stones. The choices you use are the accessories you use for ERCP. You can use BML, laser, whatever, until you clear the stones, and then you can remove the lamps. And because our procedures are done under IV sedation, we may take a few sessions for the stones to be completely cleared. And we repeat them 2 to 4 weeks each time until it's all cleared and remove the axial stent. So for this is you can use laser. You can in fact also use EHL or basket to retrieve the stones. And you can also, at the very end of the procedure, do a cholecystogram where you inject contrast in the gallbladder. And for this case, there was an incidental finding of a common hepatic duct stone. So ERCP was done in the same session. So in fact, EUS GBD, when compared to percutaneous drainage, we all know this landmark trial by Teo. It showed that when you compare EUS GBD with a PT GBD, EUS GBD has much less 1-year adverse events rate, much less recurrent acute cholecystitis, less reintervention within 13 days, and less unplanned readmission. And all these readmission and reintervention from the percutaneous group is from catheter-related problems like tube blockage or skin site infection. And in fact, with EUS GBD, probably because the lumen is much bigger, the pain reduction is much quicker and better than a PT GBD. And in that study, a logistic regression analysis showed that the predictor, only single predictor for recurrent acute cholecystitis is in fact the use of a PT-GBD. So if we compare the endoscopic options, there are in fact a lot of studies comparing, in fact also meta-analysis, comparing EUS gallbladder drainage and transpapillary drainage. And it shows that in terms of the technical success rate, EUS GBD is better. In terms of clinical success rate, it tends towards better for the EUS group. And in terms of overall adverse events rate, it's similar, but specifically EUS GBD has less pancreatitis, as understandably it did not touch a PD at all. And in terms of recurrent acute cholecystitis, EUS GBD is also much better. And if you compare the three together, PTC, ET-GBD, and EUS GBD, in fact, it shows that with EUS GBD, the technical success rate is similar to the percutaneous drainage group. Clinical success, it's similar between the PT-GBD and also EUS-GBD. And in terms of the number of procedures required, PT-GBD is required to achieve clinical success. PT-GBD is much higher. And for the long-term adverse events rate, of course, percutaneous drainage is much higher. And in terms of this network meta-analysis comparing these three modalities, and if you look at the chart, PT-GBD is also has a very high technical success rate, but the problem is also with the adverse events rate that comes with an easy procedure, which is a PT-GBD. And in terms of recurrent cholecystitis, EUS-GBD is also ranked best amongst the three. And in terms of reintervention, also EUS-GBD and ET-GBD are better than the percutaneous drainage. So to summarize, in fact, these are the three options we have. EUS-GBD, if you are used to the procedure, there is a high technical success rate and a low recurrent acute cholecystitis rate. For ETGBD, there are lower rates of reintervention, lower unplanned admission, but the procedure itself is technically more demanding. For PTGBD, it's an easy procedure, routinely done with high technical success rate, but the reintervention rate is the highest. So apart from acute cholecystitis, we can also do this procedure in patients who are already on a long-term percutaneous tube. So some patients have a cystic duct stone that is blocking the cystic duct and therefore requires a long-term PTC, which is sometimes a hassle to the patient. And in these two quite old studies, it showed that it's feasible. But doing EUS GBD in patients with PTGBD is actually much more difficult than doing a acute cholecystitis. First, because the gallbladder wall must be thickened and contracted, because the acute inflammation has subsided and it heals with a fibrosis. And second, sometimes the cystic duct may or may not be patent. And sometimes for these patients, we inject through the PTC to try to distend the gallbladder. But then sometimes if the cystic duct is patent and the gallbladder wall is thickened, you may not be able to distend the gallbladder at all. And third is sometimes the wall is so thick, and because when the gallbladder contracted, it's further away from the duodenum as compared to when it's distended. So it may be more difficult to puncture a gallbladder which is further away. And of course, after the procedure, if you're not sure, always keep the PTC in situ for at least overnight, because if anything happens, if the PTC is there, then at least the gallbladder has a means of drainage and it can manage a lot of complications. And the last thing is, if it is really technically difficult, ETGBD is always an alternative, or a long-term PTC. Actually, sometimes it's unavoidable. So this is a video of a PTC convert EGBD in a contracted gallbladder. So you can see, despite injection of the gallbladder was not very distended. For this patient, the cystic duct was obstructed, so it's already not the worst. So you can see that the distance is quite far away. So needle first approach was attempted. So you can see that it was so contracted that with the needle, it actually pushed away the gallbladder. So you can't see the gallbladder here. So this is a gallbladder. So this is the very large interflange distance. So with a second puncture, the needle went in. It was confirmed on contrast. And of course, a guide wire was then inserted. So afterwards, a hot axe EUS was used. But now you see that despite the scope, the duodenum and the gallbladder actually has quite some distance between. So it's not directly next to it. So reminding you that the interflange distance of an axe EUS stent is 1 centimeter. So the distal flange is nicely deployed, and you see that the proximal flange is being deployed. And you see the stent, in fact, proximal part of the stent. And the scary thing is, even you see it, it can still disappear. Because the gallbladder is actually pulling back the proximal flange. So the interflange distance was too long, so you see the proximal flange is right here. Because the gallbladder is contracted, so it's impossible to pull it towards the duodenum. And so now the gallbladder is actually pulling the proximal flange away from you because the interflange distance was too much. And so in these situations, first you have a guide wire, you have a PTC, so everything is very controlled. So to salvage this situation, then you can insert a fully covered stent. Yeah, so you can insert another fully covered stent, or you can insert another lens. So You see that the stent is now being inserted. So a 4 centimeter stent was chosen, and then the stent was deployed. And because the PTC is in situ, you can still do a cholecystogram to check that there is no leakage. And so I think this video shows that when we do this procedure, it can be difficult. Second, the choice of stent is important because there are actually lamps that has a much longer interflange distance. So for the Spexis and the Zeus stent, there is an interflange distance of 2 centimeters and 3 centimeters. So in fact, if we did use those stents with a larger interflange distance, this probably would not have happened. So knowing your accessories and also choice of stents is also important. So then the next controversy now, so EUS GBD is now very widely performed, is that after doing this procedure, what's the next step? So should the lamps be kept on for long term? Should it be removed like us? So you do call a cystogram, remove the stones and remove the stent. So if you look in this study just published last year, it compared the 3-year follow-up for patients who had this procedure done. And for this, they inserted the lamps for long term. They found that the adverse events rates was up to 26% if you keep it long term. However, most of it is related if the lamps is inserted in a gastric location. So if you're planning to put the lamps for a long term, so for example, the patient is very weak, you do not want to insert scope again, then perhaps a duodenal puncture for the EUS GBD is a better option. And to answer this question, in fact, I performed this comparison between our patients who had the lamps removed and patients from Dr. Manolo in Spain. So for him, all of his patients, he keep it for long term. For us, we have all along go for the aggressive approach where cholecystoscopy and lamps removal was done. So for the past 10 years, we compared all our patients. And in the ITT analysis, it showed that there was more recurrent biliary events in the group with cholecystoscopy done. So in terms of recurrent cholecystitis or recurrent cholangitis, it was more in the cholecystoscopy group. And also there was more late complications and more emergency room visits. And if you look also at the Kaplan-Meier curve on the biliary event-free probability, the long-term lamps seems to have a better comparison. But of course, within this group of patients, there were some patients who crossed over to the other group because some of our patients who were too old and frail or those who refused a cholecystoscopy, so they became a long-term lamps. So we also did a per protocol analysis. So in fact, with the per protocol analysis, the results were the same. So for the cholecystoscopy group, there was more biliary-related events and also more late complications. And of course, for long-term lamps, we worry about stent erosion and stent complication. But if you look at this data, it seems that there was no difference in the long-term lamps group as compared to the cholecystoscopy group. Of course, the follow-up time is only a bit more than 2 years. So whether it will cause more problems with a longer follow-up, we do not know. But these patients are frail patients, and you do not expect them to survive for very long. So these are just some food for thought. So this comparison, actually, the conclusion was that with a cholecystoscopy and lamps removal, there was more recurrent biliary events in both the ITT and per protocol analysis. So perhaps for patients who are very frail, we may consider to keep the lamps for long term. And how many patients, how many procedures do you think is enough number of procedures to do it independently? So in this study comparing the outcomes before 25 procedures and after 25 procedures, there was a significant improvement in procedure time. There was much less unplanned procedure events rate and 30-day adverse events rates if you perform more than 25 procedures. So maybe you would need at least 25 procedures for a EUS GBD to be independent, or call yourself an expert endoscopist. And of course, the next question is now we're moving on to whether this procedure can be done in surgical patients. The argument now is, if the patient is planning for surgery in the future, should we puncture the antrum rather than the duodenum? Because as surgeons, we know that repairing the antrum is much easier than repairing the duodenum. So there are actually studies already published. So in this first trial retrospective comparison between EUS GBD and PT GBD who had surgery afterwards, it showed that with the EUS GBD, the time from drainage to OT is much longer, but the OT time, procedure time itself is much shorter. And so this first study actually concluded that at least lab chole after EUS GBD is safe and feasible, and there's a very low conversion rate. So this is one of the videos where robotic cholecystectomy was done after an EUS GBD, and this little adhesion here is probably where the lens was before. So the rest of the procedure then is like a normal lab chole. So the adhesion may not be as bad as we expect. Also, our friend Kunda has published this interval cholecystectomy after EUS GBD in DDW, and for him, he was able to do cholecystectomy in all of these patients. He did a transduodenal approach. The lens was removed before the surgery to allow the fistula to heal before the surgery, and the only 2 of the patients required conversion, and the mean operative time is 44 minutes, believe it or not. So, and also this year, Amy Tyberg from the States also published this study comparing cholecystectomy after EUS GBD and PT GBD. And you can see that for the EUS GBD group, the procedure time is much faster. The technical success rate is similar. And the conversion rate is also quite similar. So maybe it is not as horrible as we think. And whilst everything is pointing towards supporting this approach, G and also Cheyenne from the States published this letters to editor in Gut and saying that it should never be done in patients with who are potential surgical candidates. So in fact, it says here with a very strong wording saying that that the EUS GBD should only be reserved for a selective cohort of never surgery patients. So it then gave, in the literature now, everybody is a little bit, okay, so should we do it or should we not do it? But if you look into the small details, it was only a cohort of 25 patients, and 3 of them had a conversion. And I think 1 of them had a bowel duct injury, but it was not a direct comparison between PT-GBD, right? So we all know that we should, single arm cohort does not have any meaning and there's no comparison. And these difficult gallbladders, in fact, should be compared against percutaneous patients who had PT-GBD done because they are the same group of patients. So anyway, this is still out for debate, and maybe we would need further studies to prove this. And how about using EUS GBD as a definitive treatment? So even for surgical patients, if we clear all the stones, can we consider not to take out the gallbladder in the long run? Because in the past, if you are senior enough, you know that they do PT-GBD, they dilate the tract, they do a percutaneous cholecystoscopy, they clear all the stones and they remove the PTC, but it always ends up in gallstone recurrence. So this is a very, very old, that lots of studies have been done before. So can EUS GBD change this, or do we have any new methods in preventing the gallstones from coming back? So to answer this question, in fact, in our center, we did 30 patients who are surgical candidates for EUS GBD. And during the same year, it took 1 year to recruit all these patients. During the same year, we had 79 patients who with acute cholecystitis who underwent lab chole, and we did a retrospective comparison between the 2. So of course, there was the comorbidities are very similar because they are all fit patients. For EUS GBD, we routinely screen the CBD for bile duct stones during the index procedure for gallbladder drainage. So you can see that the concomitant CBD stone rate is actually much higher. So in fact, when we do emergency lab chole, I'm sure there is, even the liver function is normal, there is a 20% chance that there is a CBD stone. So this is a fact that we know. So we compare these two, the short-term outcomes. As expected, EUS GBD is much better because patient can eat the next day. There is no chance of bowel injury. The time to resumption is diet is much quicker. There's no ileus, there's no wound infection. So short-term outcomes must be better. But these patients are surgical candidates, so we're looking for long-term outcomes. So whether these gallstones will come back that cause clinical problems. So for our 1 year comparison, you can see that for EUS GBD, so for the EUS GBD group, we all do cholecystoscopy, we clear all the stones and we remove the lamps. So at 1 year, you see that 4 out of 30 of these patients had a recurrent CBD stone. One had biliary pancreatitis, one had cholangitis, and one had recurrent acute cholecystitis. And some of these CBD stones or pancreatitis may have been induced by the cholecystoscopy, because during cholecystoscopy, we need to fragment the stones into smaller stones. And during flushing, the small stones may have been flushed down to the CBD. We're not certain. So these are the early outcomes. So for lab chole, you see, in fact, out of the 80 patients that we have, 4 of them also have some biliary events. This probably is due to some missed CBD stone during the index surgery. So there was no difference in unplanned reinterventions, unplanned readmissions, and so we further went on to look at the 2-year outcome. At 2 years, more gallstones came back for the EUS GBD group and caused more biliary-related problems. And for the lab chole group, as our surgical wisdom has taught us, after the lab chole, after the first year, second year, the patient did not have any other biliary-related events. So it stayed at 4 out of 80. So statistically, it started to see significant difference between EUS GBD. And because of these recurrent biliary events, patient required more unplanned reinterventions and unplanned readmission. And at 3 years now, so this year is 3 years, you see that 2 more of these patients, so 10 out of 30 of these patients actually had recurrent stones, and then the lab chole group, then it remained static as expected. So at this juncture, this procedure as a definitive treatment for surgical patients definitely is not the gold standard. But if some of the patients strongly refuse a lab chole, this is an option, but you need to counsel them that we know that the gallstones will come back, and we know that they will cause biliary-related problems. And of course, we are trying to look into our database now to see if we can select better patients. So which patients may have, because as you can see, 20 out of 30 of them did not have recurrence. So which the patients are these? Are the stones smaller or cholesterol stones, or the type of stones may be a bit different? So we're trying to analyze to see if we can find any better selection criteria. So to end my lecture, in non-surgical candidates, endoscopic drainage are superior to percutaneous drainage. In surgical candidates, lab chole is still the gold standard. Lab chole after EUS GBD seems to be safe and feasible. And EUS GBD plus cholecystoscopy for surgical patients are associated with better short-term outcomes, but in the long run, more recurrent gallstones. And perhaps further studies are required to answer questions on whether EUS GBD is suitable for surgical candidates. Thank you.